Hello, good afternoon, good day, everyone, and welcome to the NETEC COVID-19 webinar series. Today we are discussing ventilator support for patients with COVID-19, initial approach and advanced modalities. And I am Sonia Bell. I am the Assistant Director for the Serious Communicable Diseases program at Emory University and also one of the project directors for NETEC. We have three major pieces of content today. So after the welcome, we'll have ventilator strategies by Dr. Vikram Mukherjee. Sorry, Vikram. Second section, challenges to using non-invasive ventilator devices for invasive ventilation if needed for surge capacity use by Frank Freihart and Dr. Klopman. And then adjuncts to mechanically ventilated COVID-19 patients by Dr. Sullivan. And then we'll end with some NETEC resources and also answer some questions and answers with NETEC should we have enough time. The National Emerging Special Pathogen Training and Education Center. Our mission is to increase the capability of the United States public health and healthcare systems to safely and effectively manage individuals with suspected or confirmed special pathogens. For more information, you can always check us out at www.netec.org or email us at info@netec.org. Kind of an overview on what NETEC does. We do in-person assessments. Of course, we don't do those of late recently, but we do that to empower hospitals to gauge their own readiness. We also can help measure facility readiness using metrics. We provide education. Of course, this is one example of what we do here today. Those are didactic and in-person as well as webinars and online. Technical assistance, which can be on-site and remote. We also have an online repository and exercise templates. And then our research network, where there's an online repository and also a centralized IRB and a specimen biorepository. All right, and then I will hand this over to Dr. Vikram Mukherjee for the first section. Thank you.
Thank you, Sonia, and thank you for everyone who's here for your time. For the next 50 minutes or so, the four of us will go over some basic ventilator strategies. I'll start off with an approach to a patient who comes into your ED or your ICU with COVID pneumonia and go over a brief description on how they behave and what we can do to help them. So as you probably know by now, almost all the critically ill patients with COVID-19 predominantly present with acute hypoxic respiratory failure. It is a primary respiratory process, though multi-organ failure and multi-system dysfunction follows quite often. And there are some common themes. Like I mentioned, it's predominantly an acute viral pneumonia causing acute respiratory distress syndrome. There can be significant degrees of shunt fraction and dead space fraction, high sedation needs in the majority of our patients, which ultimately leads to or contributes to a prolonged need for mechanical ventilation. That said, there are some variations as well. We found that not one size fits all, and there are variable responses to positive end expiratory pressure. There are variable degrees of compliance noted as well. Next slide, please. This is the classic X-ray in a patient coming to your ICU with COVID ARDS. As you can see here, it's bilateral infiltrates on your X-ray without an obvious left ventricular cause. And this is very much exhibited in the way they behave on the ventilator as well as in their issues with gas exchange. Next slide, please. And most of them will present with hypoxia. So I'd like to go over the spectrum of tools we have to offer our patients when they come to our hospitals with hypoxia. We can obviously start with nasal cannula, but around a significant number of your patients will present minimally hypoxic, but will then go within hours to needing full ventilatory support. In this escalation process, there is a role for high flow nasal cannula. There is definitely a role for early prone positioning, and we'll talk about this more in a bit. If you do end up using non-invasive ventilation in the traditional way, please do so with a lot of caution. We'll talk about why this is not your first tool in battling a patient in respiratory distress with COVID. And lastly, invasive mechanical ventilation. So this is one of the reasons why non-invasive might not have a big role to play. This is a Florali study from a few years ago, 2015, which looked at the role of, which had three arms: the non-invasive ventilation arm, standard oxygen, and high-flow oxygen, and looked at Kaplan-Meier curves of survival up to 3 months out. And what it clearly shows, especially in patients with severe ARDS, is that there is a mortality downside if you use non-invasive ventilation compared to high-flow oxygen. Multiple reasons why this occurs. One is that we know very well that low tidal volumes, lung protective strategies are essential in managing patients with ARDS, and non-invasive ventilation, however much you try, can't quite offer you up to 6 cc's per kg of ideal body weight. So for that, this is one of the reasons why you shouldn't be using non-invasive as your first pass in patients with acute hypoxic respiratory failure from COVID. Next slide, please. Other reasons include, like I mentioned, inability to reliably deliver lung protective ventilation to the baby lungs. Non-invasive is a big aerosol generating procedure, and this puts at risk your entire team for nosocomial transmission. Not even if you do it in a negative pressure room, there is a possibility that there is aerosol generation and your team's being exposed to infected aerosols. We know well that COVID, while it begins with a respiratory process, quickly can proceed to multi-organ failure, and one of the big organs that fail are the kidneys, leading to uremic encephalopathy. As you can imagine, a patient who is not able to protect his airway on non-invasive can lead to a catastrophic aspiration risk. And lastly, prone positioning has a major role to play in patients with COVID ARDS. And when you are a non-invasive with a probably insecure airway, prone positioning needs to be done with a lot of caution. Next slide, please. So I would suggest that unless you're really careful, you should go from nasal cannula to high-flow nasal cannula to invasive mechanical ventilation. Once you have intubated a patient for COVID ARDS or COVID pneumonia, there are certain tenets that need to be implemented. One is lung protective strategy. We know that protecting the baby lungs is key to overall recovery. So you want to go into 6 cc's per kilogram of ideal body weight. Your goal plateau pressure, if possible, should be less than 30 centimeters of water. Your goal driving pressure, which is your plateau pressure minus your PEEP, should be less than 17 centimeters of water. Don't, as in traditional models of ARDS, don't aim for oxygen sat of 100%. Any sats above 88 to 92 is acceptable. Similarly, you don't need to aim for a pH of 7.4 and CO2 of 40. You need to be offering your patients acceptable hypercapnia with a CO2 anywhere between 55 and 60, and a pH above 7.2 should be tolerated. Next slide, please. This is the traditional P2F ladder that we use in ARDS models. This is from the ARMA trials that came out in the early 2000s. What we noticed that not all ARDS patients do well on a set P2F ladder. In our first few weeks of ARDS, COVID ARDS, we were using the high P2F ladder, recognizing that these patients might be recruitable, but over time we found that oxygenation and gas exchange and hemodynamics worsened as we used aggressive PEEP titration with PEEPs of 18 and 20. And next slide, please. One of the reasons that probably happened is because of the need for a more individualized approach. Just walking over these slides, these are the traditional west zones of the lungs, and I'll just walk over one of these. If you have a patient who is normovolemic, you have capillary pressures, alveolar pressures, and matching up in different parts of your lung. A fair degree of your patients with COVID pneumonia will be hypovolemic, some of them from cytokine storms leading to insensible losses, some of them from poor PO intake. And you'll see that as you increase more and more PEEP on the ventilator, your gas exchange across zones 1, now here and here, is much impaired. And often on giving them fluids, which is often counter-intuitive in a patient with ARDS, might improve your gas exchange by getting them hypervolemic. So this is a model where hypovolemia plus PEEP essentially obliterates all capillary blood flow into your lungs and worsens gas exchange. So you want to be a bit careful about that and have a more individualized approach rather than give everyone a set P2F ladder to follow. Next slide, please. Prone positioning. In traditional ICUs, we used to use prone positioning in patients who were intubated with severe ARDS, and we used to implement the prone positioning bed, the rotor-prone bed, to flip our patients. In the COVID models, the surge of patients that we had to implement manual proning, which we now have quite a routine for. But also think about proning your patients who are not intubated yet, and they would benefit before intubation on high-flow nasal cannula. We're following the same data from the Perceiver trial, which suggests that prone positioning should be done for prolonged periods of time. So our proning team used to pronate at 3 to 4 p.m. in the afternoon, let the patients rest on the bellies all night, and then supinate around 9 or 10 in the morning. So around a 16-hour prone window per day. Reassessment needs to be done daily, and as long as the patient, sorry for the typo, meets criteria for P2F less than 150 and a PEEP of less than 10 centimeters of water on a FI of 60%, they would need to be proned again. Of course, remember these patients have multiple lines and tubes in them, central lines, A lines, hemodialysis lines, ET tubes. So any change in positioning needs to be done with caution. Extubation and unexpected extubation in this patient would be catastrophic. So please make sure that your airway is, among other things, is maintained as soundly as possible. And you need to have a protocolized approach. Here we used a nursing and a respiratory therapy driven team to be able to prone these patients. But the point I'm trying to make is that if you have patients with ARDS, please make sure you have an active proning team changing the position of the patients on a daily basis if needed. Next slide, please. Sedation and neuromuscular blockade, a significant issue, and we are now paying the consequences of that. In our patients, we had to sedate them much higher with much higher sedative medications than we were used to in the past. Again, the cytokine storm, their catechol surge made them extremely dysynchronous with the ventilator, and there was a consistent need for making them synchronous so that they don't double trigger, so that they don't cause transcellular injuries to themselves and we were sedating down to a RASS of -4. Conventional medications, fentanyl, propofol, and ketamine, but we were sometimes compelled, however much we didn't want to use benzodiazepine drips to sedate our patients. And around 30% of our patients needed neuromuscular blockade in the form of cis-heterochrome drips to keep them synchronous and paralyzed on the ventilator. So this is essentially a possible approach that that you might use. This is what we were using. Essentially, anyone who is intubated would get lung protective strategy, an early and aggressive prone positioning algorithm, very careful individualized PEEP titration, neuromuscular blockade, and inhaled NO for the patients who had refractory hypoxia, and lastly, ECMO evaluation based on existing guidelines on whether to provide someone VV ECMO or not. We did end up putting a fair number of patients on ECMO with mixed outcomes, but please remember that that was after all the other steps had been exhausted in terms of providing critical care support to the lungs. Lastly, and I was mentioning this earlier, now towards the tail end of at least our New York City's COVID experience, we're seeing the long-term consequences, and they are not pretty. Of the survivors who lived through their acute phase of illness, a significant number of them have progressed to fibroproliferative ARDS. We've got a few CAT scans on patients a month or 6 weeks out of their initial admission, and it's striking to see how much end-stage fibrosis their lungs have progressed to. There is, and now we're recognizing, and we were anticipating this, that there is significant post-ICU syndrome. We had to use paralytics, benzodiazepines, steroids sometimes as well, which now we're looking at the neuromuscular weakness, keeping patients on the ventilator for a fair amount of time. Delirium from the benzodiazepines used, long ICU length of stay contributed to that. And while it's too early to assess cognitive dysfunction, we know very well that 6 months, a year out, their neurocognitive decline might be pretty rampant. We do have a tracheostomy program, and we were performing tracheostomies on our patients between day 10 and day 14. This has decent outcomes in being able to liberate sedation and being able to wean the patients off the ventilator to a trach collar. But along with all these long-term consequences comes the need for a citywide response in being able to provide LTAC capabilities, not only for the pulmonary support, but also for the renal failure that comes with a fair amount in these patients. So on that note, I'll pass it off to my colleagues, Frank and Matt, and we'll field questions at the end of the session. Thank you.
All right, thank you, Vikram. This is Frank Freihout. In looking at this surge that might be coming for facilities, if you're a facility like ours where we have over 50 ICU ventilators, or if you're a smaller hospital and only have a handful of ICU ventilators, you might reach a point when you need to, open up the toolbox and utilize some devices that you already have that could be used for invasive. And I'm talking about the bi-level devices, the BiPAPs. And so there's some differences that I'll just quickly review and things to consider if you're going to use a non-invasive device for invasive ventilation. And so one of the big things you gain, obviously, is less leak because you're not utilizing the mask and the leaks around the mask, and you can hook right to the ET tube. This gives you a little better knowledge of your volumes, but still your volumes are estimated based off the calculations of the flow and the predicted leaks, although there'll be less leak if you're utilizing the ET tube. But remember, these devices are meant to have a leak, and they're calibrated for that leak. They utilize a leak port either in the mask or on the circuit. So you'll have to have one at least on the circuit. And some of the manufacturers do make a leak port that can be changed out for one, as in the photograph here, that you can place a filter on. And that would be probably your best option. As Vikram had mentioned, these devices with that leak could be spreading the virus through the room. So this would limit the amount of virus and allow you to still utilize it invasively, but limit that leak that you have in there. And with these, normally you would have some humidity from your upper airway if you're utilizing a mask, although a lot of us now utilize humidifiers on our mask devices. But you would definitely, if you're bypassing that and utilizing an ET tube, you need to have some sort of way to maintain your moisture. So one option would be a heat moisture exchanger and allow you to have another filter there. But I know some of our patients have had some quite thick secretions, so in order to not dry the mucosa and whatnot, if you had the option for active humidity, that would probably be a better option with some of these COVID patients. And when possible, hopefully your non-invasive devices have the option or have the ability of high pressure oxygen, so you can set a specific FiO2. Many of these patients have a requirement, a high minute volume demand. And if your non-invasive device simply uses bleed-in oxygen, where you're adding in up to maybe 15 liters, or some of the devices say they won't tolerate more than a 15-liter bleed-in, then at a high minute volume, you're really limiting what kind of FiO2 your patient might be able to get. So if you have the ability to have one of the devices that has high pressure oxygen available, that would be your best option. And then as far as modes, you definitely need a mode that you can get a set respiratory rate, and hopefully a set I time, and ability to see what kind of volumes you're achieving with that. So whether it's a spontaneous timed mode or the pressure control mode, or even an AVAPS mode, average volume assured pressure support, where you can dial in that they've got their backup rate and they've got a set I time, and so you can kind of follow and see what you're doing with your minute volume would be the best. A lot of these devices, the alarms are set very low or sometimes off because we know we have a lot of leaks when we're using them traditionally as non-invasive with a mask. So you want to make sure that those alarms are activated, so at least you know of a disconnect, since this is your total life support with these patients, utilizing it through an ET tube. And one of the other things to be aware of is the pressure gradient differences on your non-invasive, your IPAP and EPAP, versus if you're on a traditional ICU ventilator that most of us get used to. The majority of manufacturers with the ICU ventilators, when you adjust your PEEP, your pressure above the PEEP goes up with it. So in other words, your volume delivered or the stretch delivered is about the same. The example would be on your IPAP and EPAP on a non-invasive device. They don't follow each other. They set separate. So if I had 10 of IPAP, the inspiratory pressure, and 5 of PEEP, EPAP that was set and my patient wasn't oxygenating well enough and I needed to go up on the bottom on the EPAP, if I went from the EPAP up to 10 and my IPAP stayed at 10, my total airway pressure is only 10. I'm no longer ventilating and I don't have a pressure gradient there. So it's just something to watch anytime you're making pressure changes on a non-invasive device to make sure you're achieving the volumes and the pressure gradient that you were hoping for. And then looking at the volume targeted modes like the AVAPs or the IVAPs, the ICU ventilators in like PRVC or volume guarantee type modes, they have a relatively very quick response. They're designed obviously for the ICU. Most of them look breath to breath, and so they can make immediate changes if there's lung compliance changes to try and maintain the tidal volume that you're targeting, and thus you're to keep your minute volume where you were hoping. Whereas the non-invasive devices, oftentimes, because they're made for more of a chronic patient and they are looking at a lot of leaks when you're utilizing a mask, but here if we're using it invasively, just to remember that those algorithms are a bit slower. Oftentimes they're looking at either a minute or a couple of minutes to average or several breath average in their algorithm before they start making pressure changes to make sure that you're getting the delivered volume. And beyond that, some of the devices then also allow you to adjust how much pressure per change. And so you want to make sure that those things are dialed in to get you as quick a response for your critical patient as possible. And I think this goes to Matt.
Thanks, Frank. I wanted to spend just a few minutes talking about part of what is amounting to a surge plan in many facilities across the country, and that is what happens as I start to run out of my traditional ICU ventilators. So Frank just gave us a really nice overview of how we can use some of our traditional non-invasive ventilators in an invasive capacity. And I wanted to spend just a few minutes talking about some of the considerations necessary if we want to think about converting our anesthesia machines into invasive ventilators. And the first thing I wanted to talk about just very briefly here, and we'll hit it a few more times over the course of my slides, is the difference between a traditional ICU ventilator we see on the right and an anesthesia system on the left. As we know, on the right, in our traditional ICU ventilators, we get fresh gas, we pressurize it, we usually humidify it, and then we pass it to a patient's lungs. And it's a one-way system. So once we exit the patient lung, that exhaled breath goes in a one-way fashion, moves along through the expiratory valve, is typically filtered, and makes its way out into the room. An anesthesia machine, on the other hand, is really best studied by the slide over here on the left. So what we can see on the left with the anesthesia machine is that they have something called a circle system. And in this slide, I guess it's best depicted as an oval more than a circle. But what you can see here is that air is pressurized, air and oxygen, either via a bellows through a ventilator or through a bag. And whether you're pressurizing via the bellows or via the bag is selected by a switch. And then that is pressurizing the circuit. And fresh gas comes in, it makes its way through the inspiratory valve and on into the patient's lungs through this Y piece here. And on the way back, it goes through the expiratory limb. But this is where it's different. It can pass through a CO2 canister or a CO2 absorber, have the CO2 scrubbed out of the exhaled gas, and then mixed with the fresh gas again. And in this way, a patient can rebreathe. So the differences in the way that we think about an anesthesia machine from an ICU ventilator, there are many, but here are the basic considerations we need to work through as we think about deploying an anesthesia machine as a fixed ICU ventilator. Number one is that much like an ICU ventilator, these machines need to be started up by a trained individual. And the difference here, of course, is that the trained individuals for most anesthesia machines are anesthesiologists and anesthetists. Also, these machines are meant to be used in anesthetizing locations and are therefore designed to be fully and continuously attended by trained personnel and monitored all of the time. A couple of the implications of that are that our alarms aren't as loud. The max volume on most anesthesia machine alarms is not as loud as ICU ventilators. So we need to make sure as we're setting these up that we are going through the process of checking the alarm limits, but also making sure we're turning up the volume, because the default volume of alarms is not nearly what we're used to from our ICU ventilators. We talked a little bit about rebreathing and the implications of rebreathing, namely that we have to manage the CO2 of exhaled gases if rebreathing is occurring. But the other implication of rebreathing is that there's an increased buildup of condensation in both the breathing circuit the portion that we can see and the portion inside the machine. And we know that prolonged exposure to high levels of moisture on the inside of the machine can lead to breakdown of some of those inspiratory and expiratory valves. So this is something that we have to mitigate, and we'll talk about that in just a few minutes. And because of that consideration, we typically prefer the use of heat and moisture exchangers rather than active humidification. So it's really more of a passive humidification process. Another difference in anesthesia machines as compared to our ICU ventilators is that they require daily calibration. Now, this really takes on a number of different flavors depending on the specific manufacturer of an anesthesia machine. But it's important to note, at least with some of the manufacturers, that if this 24-hour check isn't completed, then some of the compliance data that is taken when you first start up the machine that makes the measurement of your tidal volumes and thus your minute ventilation accurate, past 24 hours, if you were to temporarily pause ventilation, that compliance data is lost, and your measured volumes, the accuracy of those measurements would then go down. So it's an important thing we've got to keep in mind as we move through the considerations of putting these into prolonged use. Another difference is that unlike a lot of our sophisticated and even mid-grade ICU ventilators, our anesthesia machines, because they're meant to be continuously attended, don't have an automatic leak compensation function. They will often alarm at you when they detect a leak, but they don't have the ability to increase flows to compensate. A similar limitation is that when we think about the spontaneous modes of ventilation with which an anesthesia machine can be programmed, most of them don't have an automatic backup, meaning that if a patient experiences apnea, again, the machine will alarm at you, but in most of the situations, it will not default back to a backup mode. Now, there are some manufacturers and some modes within these machines that are available typically for an enhanced purchase price. So some of our anesthesia machines, in fact, do have the backup mode, but you'd want to be very familiar with the modes that were available to you and whether or not this feature was present. And lastly, one of the big differences is that in the setting of an obstruction or a patient being desynchronous with the ventilator, the pressure often doesn't pop off until we see really high pressure, sometimes in excess of 110 centimeters of water. So ensuring that there's synchrony with the patient is very important when using at least some subset of our anesthesia machines. I want to remind everyone that while using an anesthesia machine in a prolonged fashion as a substitute for an ICU ventilator is never our first choice, the FDA, in a situation where a hospital's available conventional ventilators were all being used and the need to ventilate patients exceeded the available supply of traditional ventilators, is allowing during this public health crisis the use of anesthesia machines in an off-label fashion. And they have committed to no enforcement action, and additionally have given guidance around some prolonged use of disposables and other components that typically would not be expected to be used for several days in a row. So I just want to stress that this is off-label guidance. Now, that said, every major manufacturer of anesthesia machines has put out guidance to providers and facilities to help step their equipment through a conversion from an anesthesia setting into an ICU ventilator setting, and some of those references are included in our slide deck. And in a minute, we'll go through some of these equipment and staffing considerations. From an equipment perspective, we talked a little bit about system startup. We want to make sure that someone is there who is familiar with the equipment. We typically, when thinking about an ICU use, would remove our anesthetic vaporizers. And similarly, those machines need to be flushed to ensure there's no residual anesthesia gas within the internal components. There's a very small percentage of the population that is susceptible to a condition known as malignant hyperthermia, and we wouldn't want to inadvertently trigger that in any of our patients being placed on long-term ventilation. We also need to make sure that in order to perform that system check we described earlier that typically happens on power up of the device, needing to do that at least every 72 hours, recommended in usual state is every 24. During that time, the machine will be completely non-functional. Different connections have to be made, purposeful obstructions have to be caused, and so because of that, when we're performing these checks, we have to have alternative ventilator equipment available. We talked about the HME or the HMEF, this heat moisture exchanger. The F indicates there's a bacterial and viral filter. We recommend that 2 of these are in place. The full HMEF would be closest to the patient. we'd want to make sure that our sample line for end-tidal CO2 monitoring was on the machine side to keep the gas bench clean. And we put an extra bacterial and viral filter on the expiratory limb where it meets the machine to keep the machine internals clean. As I mentioned before, if we're able to keep the fresh gas flow higher than the minute ventilation, it will reduce or eliminate the amount of rebreathing going on, which will prolong the shelf life, if you will, of the CO2 absorber that's in the system, and in many cases can't be eliminated. So this will allow us not to go through that disposable, which if this happened on a mass scale would likely become a limited supply resource. We recommend adding water traps in line, and I'm sorry I don't have a picture here, but often we'll add a water trap into the circuit to catch that excess condensation and prevent it from either backing up in the circuit or making its way into the internal components. And when thinking through where best to stand up this kind of activity, one has to think through the pros and cons of all of our different physical spaces across the hospital. So we know that in the OR, all of the necessary connections are present: the gas lines, the scavenging system, suction, etc. But it's often not practical to go OR to OR, though it has been done, especially in places like New York City. Other centers look at deploying these into an ICU environment, and one simply needs to make sure that you partner with your facilities team to investigate the availability of both the supply gases and the suction necessary for waste gas scavenging. For the bellows, on an anesthesia machine, some of these are electric. They're driven by electricity, and some of them are driven by high pressure gas being pressed in around the bellows to cause it to drive ventilation of the patient. For those systems that use drive gas that are pneumatic, they all come programmed to use oxygen. And while that is preferred as it's a safety, an added layer of safety in the case of a breakdown in the barrier between the bellows and the outside housing, there is the ability to convert that to compressed air. That would just need to be done by a trained technician if there were ever concern about lack of oxygen availability. And lastly, excuse my typo there, the scavenging system, as I mentioned a moment ago, is a way to get rid of waste gases, typically that would contain a volatile anesthetic. If you don't have the ability to hook that up, for example, if you're going to deploy an anesthesia machine in an ICU, that same trained technician that could change the drive gas would need to spend just a few minutes with the scavenging system to disable it. Again, we're not using volatile anesthetics, and we're filtering the exhaled gas, so it's safe. But there are some nuances manufacturer to manufacturer that have to be taken into account to ensure that we don't inadvertently drive high pressure into the ventilation circuit. And then lastly, in just thinking through how one might stand this up, we know that most facilities where anesthesia machines are present have some number of anesthesia personnel available. And in almost every instance where this has been described, there's been either continuous attendance by an anesthesia personnel or a rounding schedule that's been set up whereby an anesthesia personnel makes rounds on all of the anesthesia machines being used as an ICU ventilator at a fixed schedule, and they maintain immediate availability in the case of alarm. Some sites have also cross-trained individuals within the care team. Respiratory therapists are probably the best example of this, both in the basic settings, because frankly, the programming of an anesthesia machine's ventilatory settings is very similar to that of an ICU ventilator. Same settings, just different buttons and clicks. So both on making some changes to the basic settings and in responding to the initial alarms in case the anesthesia personnel isn't right there at the moment. And we just want to make sure that, much like ICU ventilators, that we're limiting any parameter changes only to those anesthesia personnel and other members of the care team that have been trained. And when thinking about rolling this out, obviously, the more you can geographically cohort patients being ventilated with an ICU ventilator, an anesthesia machine as an ICU ventilator, the easier it is to maintain kind of that immediate availability of the providers to provide both the rounding and the emergency backup support. These are some of the references that are available. The ASA, the American Society of Anesthesiologists, has put out a guide about how to do this, and there's a lot more detail in there than what we've gone into today. You'll see the FDA guidance noted there, as well as all of the major manufacturers' individual technical guides on how to complete this in partnership with your biomedical engineering teams. And I'll pass it off to Dr. Sullivan.
Good afternoon. My name is Jim Sullivan. I'm an associate professor of anesthesiology at UNMC in Nebraska. I'm part of the biocontainment unit here, and it's my privilege that you all showed up to listen to this. My part is essentially what happens when it all goes wrong, when all the things that we possibly have really don't work, and we need to do something different. Can I have the next slide, please? So this is one case at Nebraska that we took care of over the course of the last 4 weeks. It was a 32-year-old Asian male. He had absolutely no previous history, but upon presentation, he was found to have an A1C of about 10. He was COVID positive at an outside hospital 4 days prior. He was sent to home quarantine, but over the course of time became more symptomatic and presented back to our hospital. He was feeling comfortable and mildly short of breath, but as is the case in many of these patients, which we don't understand, his oxygenation saturations were found in the 20s. They placed supplemental oxygen on him, did not respond to neither high flow nasal cannula or regular nasal cannula, and he was emergently intubated in the emergency room. His initial settings, we tend to use pressure regulated volume control here at the Med Center. That's the primary mode of ventilation we have on most of our patients, and the one we're most familiar with. Initially, his FiO2 was at 100%, and his PEEP was at 18. Tidal volume was 360, which was approximately 6 per kilo. He was prone and given muscle relaxant and stayed that way for approximately 11 days. We had absolutely no change in his clinical status. And then we go to the next slide. He got significantly worse. So on day 14 of illness, day 10 of hospitalization, which we see fairly often in the second week, the patients clinically decline. And again, in my mind, there are two types of these patients. There are those happy hypoxics where their mechanics are completely normal. They're just impossible to oxygenate. And then there's the true on ARDS with the decreased compliance, high plateaus, which are very, very, very difficult to care for. On day 14, the best tidal volume we could get was approximately 150 cc's. That was about 2.5 cc's per kilo of ideal body weight. And that was with plateaus of 48 to 50, which is completely outside the realm of what we want. We tried the best PEEP challenge, in which case you take the PEEP at the level that you have, you slowly walk it up over the course of time, going up approximately 2 millimeters of water every so often, and try and gain compliance with that. So long as you're gaining compliance, you keep going up until you hit a plateau, and then you drop it down and leave them there. The best we could do was 10 millimeters of water with no increase of compliance at all. At that point in time, we're a fairly high-use ECMO center. It was decided because of his age and his lack of multiple comorbidities at the time, he was cannulated fem-fem for VV ECMO. And then we waited. His PEEP was dropped from approximately 22 to 10 to try and lessen plateaus, and we dropped his tidal volumes down into the 150 range to rest the lung. And he still remained hypoxic despite 4 to 5 liters of flow, which is a fair amount on VV ECMO, 100% on the oxygenator, 60% of, 0.6 on his FiO2, and a PEEP of 10. And even with all of that, the plateaus were still in the 30 range. We decided to add inhaled epoprostenol. That absolutely did nothing at that point in time. Point of care ultrasound showed a cardiac function that was completely normal and in fact hyperdynamic. The CTs that we have all come to know and love, if you look here, this is his lungs on day 14. What I find interesting in most of these patients is the heterogeneous, absolutely diffuse process with some areas that are completely socked in and some areas which have some elements of oxygenation. I think this is one of the problems that we have because as we try and ventilate these concrete lungs, we do have areas of the lung that could be oxygenated, but because of the higher pressures needed to keep the lung open, it may actually significantly cause more lung damage in those areas that would otherwise be able to be oxygenated. We spent 5 days with no recovery of pulmonary function. Tidal volumes remained in the 150 range. We have the ability to do esophageal manometry here. Classically, we tend to use this in larger patients where we're worried about chest wall rigidity, or obese patients where the weight of the chest needs to be part of the calculation in terms of airway pressures. When we dropped the manometer, we found that the airway plateaus, despite the airway plateaus in the 35 range, with the tidal volumes at 2.5 per kilo, we found that the transpulmonary pressures were actually around 15 or 16. So what we did was we went ahead and increased our PEEP slowly up to 16, watching our airway plateaus on the ventilator rise into the 50 range. However, our transthoracic plateaus stayed well within the 25 centimeter of water range. We left it there for about 8 hours and did absolutely nothing except want to go hide in a corner watching our airway pressures. But what we found was over the course of 8 hours, we actually gained compliance. Both the peak inspiratory and plateau pressures decreased overnight. We got a little bit brave and we increased our PEEP to 18 and subsequently developed a small pneumothorax. We dropped the PEEP down to 16 and then we tried to increase our tidal volumes up into the 200 range. Again, our transthoracic pressure stayed well below 25. Over the course of about 3 days, we left the PEEP at 16 and were able to increase our tidal volumes up to 320 the entire time, leaving our transthoracic plateaus under 25. This is esophageal pressure tracing. Now, this is not in a morbidly obese individual. This is actually a very small man. He's only about 5'1" or 5'2", and not morbidly obese by any stretch of the imagination. Again, you can see the plateau. The transthoracic pressures at 24 at that point in time. And you know you're in the right spot because you have cardiac oscillations which match the oscillations on the manometer. This is our patient's lung by chest radiograph. On day 1, you can see a small amount of aerated lung in the upper airways. On day 2, you can see actually lung opening up on the right and left, with the left actually visible all the way down to the diaphragms. And then on day 3, both sides actually you can see diaphragm fairly significantly. So what do we do when it all goes bad? Here we've started using more inhaled vasodilators. We look for pulmonary artery vasodilatation. Here we use synthetic prostacyclin. It's synthesized on multiple organ vascular smooth muscles and works on G protein coupled receptors. In the lung, it has multiple actions. Primarily, we use it for pulmonary artery vasodilatation. We look to improve VQ matching within the lung itself. And we know that it has an inhaled, the inhaled agent has a ceiling effect around 20 to 30 nanograms per kilogram per minute. We use this both in intubated and non-intubated patients, often bleeding it in. You need at least 5 liters of flow. 5 liters? About at least 5 liters of flow in order to get it effective on non-intubated patients. The reason we've used it and started using it was we had a fair amount of right ventricular dysfunction, especially early in the course, probably related to the hypoxemia. We also use epoprostenol much more than iNOS here, or inhaled nitric oxide, because it's by far less expensive, on an order of magnitude of, I think a whole day worth of EPO is about $33, whereas inhaled nitric is about $2,000 an hour.
200 an hour. 200 an hour,
sorry. It can be used in ARDS both due to primary and secondary injury. There's no randomized trial showing clear survival benefit despite increased oxygenation. But again, this is what we're doing when it all goes bad. There's almost no systemic side effects. Blood pressure and other hemodynamics are almost not affected unless they're improved. We've had people with no urine output who have completely changed around and started pouring out urine by adding it. There's some thought that it increases surfactant via cyclic AMP. There is increased degradation at lower pH, and that's important in the setting of permissive hypercapnia. In most of these patients, carbon dioxide is not the problem. It's strictly a hypoxic event, but something to consider when hypercarbia becomes a problem. Decreases your pulmonary arterial pressure with no change in systemic pressures. And there's some thought that it may inhibit platelet aggregation, which may be a benefit in terms of recovery, but this has only been validated in the intravenous form. Inhaled nitric, it's actually formed in the paranasal sinuses. It works as an antiviral, and that's been actually validated in terms of, I think, influenza, if I remember correctly. It does work as a bronchodilator and a pulmonary vasodilator. It activates ciliary movement, activates mucus production, and it's fairly expensive. About 5 years ago, we switched. We were using a fair amount of nitric in our transplant populations, and we've since switched to inhaled epoprostenol because of that. Esophageal manometry is something we don't do a lot of here, but it's one of the things I reach to when things really are not working well. It gives us a transmural pressure of the lung, or the stress on the lung. So if you think about it, your pressure of the alveolus and minus your pleural pressure gives you that transmural pressure that you're looking for. And when there's no flow, the alveolar pressure should equal your transpleural pressures without mitigating factors like chest wall rigidity, obesity, kyphoscoliosis. That would be important in your prone patients. Under static conditions, your alveolar pressure is equal to your airway pressure. Your pleural pressure is equal to your esophageal pressure. And your transrespiratory pressure is equal to your airway minus atmospheric. Your chest wall pressure is equal to esophageal minus atmospheric. And your pleural pressures are equal to your airway minus your esophageal. So what we're looking at primarily is what your airway pressures are minus your esophageal pressures for your transpulmonary gradient. This is just a picture form of what we were just talking about, but effectively what we're trying to do is push air into lung that is not open at that point in time. The problem is in some of our ARDS calibrations, we don't establish enough pressure into the lung to overcome closing pressure of alveoli that are simply so socked in that they won't respond. And so you can get over-distension of good lung while under-distending the bad lung. So the goals of mechanical ventilation in this setting is keep the lungs open to prevent atelectotrauma. So the bad lung, the socked-in ARDS lung, we need to get those alveoli open in order to benefit gas exchange. But in tried and true lung protective therapy, we need to prevent further harm and inflammation due to over-distension. So again, these are our lungs. We've seen them. Everybody's seen these lungs on their floors. These lungs don't get better even when patients start to get better. So this is when I go to the esophageal manometry, when I have truly heterogeneously injured lung that I just can't ventilate successfully. Transpulmonary pressure is many times negative at the end of inspiration, leading to collapse, as I said before. And then we try and titrate the PEEP up to offset the closing pressure. This is a study that I rely on. Again, it is not the end all and be all. There are other studies that have shown that this may or may not be beneficial. But again, when we can't ventilate and we're only moving dead space, it's one thing that you can consider using to try and move your patients along. Under A, what we see is as esophageal pressure starts to go up, our PaOT and our arterial and inhaled oxygen levels start to separate under the esophageal pressure as alveoli are opened up. We see that in pretty much all of those curves. As esophageal pressure is titrated up, we actually gain the ability to not only ventilate, oxygenate, but to ventilate as well. That's pretty much the end of my my talk. Sonia, do you want to step up there?
Yes, thank you. Thank you again, everyone. And we do have, we'll go ahead and answer the one question in the Q&A right now. For high volume ECMO for a high volume ECMO center, why 14 days until cannulation? Do you think we as a critical care community wait too long with this trigger pull? ECMO did well in the 2009 H1N1 pandemic.
So I agree. I think maybe we did wait a little bit too long, and we've actually lessened our times in the last 2 ECMO patients that we currently have. The only thing is that we have, as an institution, we have reserved ECMO for pretty much, you have to be the ideal candidate, whereas we tend to stretch a little bit. Most of the studies that would show benefit within ECMO would be to cannulate within 7 days of initial onset. But I think the lack of understanding of the disease process and the fear to commit to ECMO when we can't offer it to everybody probably slowed us down a little bit. Now that patient subsequently did very well and has left the hospital or is just about to leave the hospital and won't even need to go to an LTAC. He's up and walking in the hall. So given that, we also have to realize that the pieces of ECMO that we rely on, the ECMO circuit itself, the pumps and whatnot, are all in short supply. And so at some point in time, we may have to say no to people. And I think that's one problem in terms of whether or not ethically you can offer to somebody and not to all. It becomes a real discussion. And so the discussion here is between 3 people, our ECMO medical director, our ECMO surgical director, and the attending physician that's caring for that patient. So do we wait too long? I think we've lessened our time here because we had a very good outcome with this patient. But in this case, we probably waited a little bit too long.
Thank you. And then also, any panelist, are you seeing an increase in VAEs in COVID patients?
I can take that, Sonia. Hi, everybody. Vikram here. Yes, definitely. We are seeing ventilator-associated events, some VAPs as well in our COVID patients. A few things that contribute to that: they're intubated or trached for a fair amount of time. And as you know, longer you're on the vent, higher the risk is. Some of them have very fragile lungs to start with, being destroyed by the viral pneumonia, and that is a perfect substrate for a MRSA or a CLEB or a pneumococcus to infect. And thirdly, a few of our patients have received steroids, and some have received anti-inflammatories, and that also reduces your immune capacity to deal with a bacterial infection. So short answer, yes, we are seeing an unfortunately increased trend towards more VAEs in our long-term intubated patients.
Thank you. And we'll go ahead and try to squeeze one last question in. Can you help me understand the precipitous decline hypoxia that we see in these patients, sometimes pre or peri-intubation?
I think there's a lot of questions that we need to answer, and that is definitely one of them. How you can go from walking in, looking fine, to being intubated in less than an hour. I don't think I understand it clinically because there's nothing obvious in my mind. I think that and the question of how you can walk in at 20% hemoglobin saturation and still be pink and making sense is another part of it that I don't think we really understand, and hopefully there is an answer. But as someone who is now working up there quite a bit, I don't understand that at all.
Thank you. Just a reminder that we are here to help. Thank you again, everyone, for attending today. We continue to build resources and develop online education and deliver technical training, such as this webinar today. Feel free to send questions to info@netec.org, whether they are technical assistance questions or issues with continuing ed credits or certificates or anything like that. We also did, of note, just receive confirmation that we got approval for AARC credit for this webinar. So if you are looking for those credits as well, that will be tied to the same evaluation link and process. And Please join the conversation. Follow us at on Facebook, on Twitter, Instagram, LinkedIn. Also, make sure you check out our YouTube channel. This video will be recorded and will be provided there, and it also will be provided at netec.org alongside the PDF of the slide deck here. And again, we thank you all for your time and with us this afternoon, and hope you have a wonderful weekend. Thank you.